Okay, guys, very last lecture in this series on electrophysiology. It's going to be a fairly quick one. This is a bit additional to what advanced care paramedics in Australia generally do. So for my students, you don't really need to know all the drugs that we're talking about in this lecture. Instead, what I want is to give you a rough idea of how antidysrhythmics actually work without memorizing details about the specific agents. If you're working as an ICP, CCP, MICA level paramedic, then you'll need to know this stuff fairly well. In other parts of the world, like if you're an NREMTP in the United States or ACP, CCP in Canada, or I'm not so familiar with the UK, but higher levels, or you're the second tier paramedic that comes in, and you should know this stuff pretty well. But for certainly undergrads in Australia, it's a nice to know, not a need to know, and I want you to have an overview, not a detailed ability to recall, okay? But we've been talking about the electrophysiology of the heart, so how we alter the electrophysiology of the heart as paramedics is, to me, relevant and also a good sort of capstone at the end of the whole thing to tie it together. So, you know this stuff now. Go to paramedicine.com. All the information's there. This is our last lecture. If you've made it this far, congratulations. At the end of this, if you have really learned the information in these 8 lectures, you will have an excellent paramedic understanding of electrophysiology, better than most. Learn this stuff and then go talk to other paramedics in the station or that you know and ask them questions about it, and you'll realize most people don't go to this depth. I think they should, but I'm kind of geeky, so my perspective is a little bit skewed. But I think that if you're working with paramedic pharmacology and antidysrhythmics, you should understand what you're doing. To me, that just seems safe. So let's go through it. Here are some priming questions. We're going to ask you to explain the Vaughan Williams classification and talk about where they work in the heart. And then we're going to talk a little bit about the following antidysrhythmic medications and have a rough idea of how they work, electrophysiologically speaking. And then I'm going to talk about something that isn't very well known. If you talk to other people about this, unless you're speaking to a cardiologist, they probably won't know about the Sicilian gambit. But in terms of studying antidysrhythmics, I think it's a much better way to organize our thinking than the Vaughan Williams classifications. So I bring it up, and you too can be a fellow geek and know about the Sicilian gambit, and you can spread that information throughout the world and help people to understand electrophysiology, antidysrhythmics a little bit better. So these are the main things we're going to talk about: the Vaughan Williams classification and the Sicilian gambit. So Vaughan Williams, this is a bit of an interesting history. In the 1970s, Dr. Brahma Singh was a cardiologist doing his PhD. And he came up with a way to classify antidysrhythmics. And for some reason, Dr. Brahma Singh's, actually he's Dr. Brahma Singh because he's a medical doctor and a PhD, pretty impressive guy. And he came up with the system for antidysrhythmic classification that everybody uses. And for some reason, and we can only speculate why, the system that he came up with is named after his PhD supervisor, who was Dr. Vaughan Williams. So this is always called the Vaughan Williams classification, even though it's not. It's the Brahma Singh classification. It's Dr. Singh who came up with it. So people are starting, in recognition of the recognition that was not given, are starting to call this the Vaughan Williams classification. You might just see it called the Vaughan Williams classification. It's the same thing. But I would encourage you to recognize Dr. Brahma Singh, who did this work, and call it the Vaughan Williams classification. If anyone says, oh, it's a Vaughan Williams this, I tend to be the guy who corrects them and say, actually, it's the Vaughan Williams classification. When they say, what do you mean? I tell them the story. So, Dr. Brahma Singh, hero in cardiology, unrecognized for years, now starting to get the recognition that he deserves because we call it the Vaughan Williams classification. So you should be familiar with this by now. If you're not, you need to go and review everything again, because this is sort of the fundamental diagram of how depolarization works. And what Dr. Singh came up with was a way of classifying antidysrhythmics by which part of this depolarization they affected. So, for example, the class 1 antidysrhythmic drugs, and they're broken down into class 1A, 1B, and 1C, block the fast sodium channels that open up in phase 0. So any drug like lidocaine that interferes with that section of the depolarization curve is called a class 1 antidysrhythmic. Pretty simple idea. Class 2s are beta blockers, and we talked about beta blockers in the last lecture when we talked about the noradrenaline jumping into the beta 1 receptors on the cell wall of the myocytes. So beta blockers are considered class 2 antidysrhythmics. Class 3 block the exiting, the efflux of potassium in phase 3. Class 4 are calcium channel blockers. And then later on, a little bit after Dr. Brahma Singh, we added a class 5 because we realized it doesn't quite fit with this. And what we've come to realize is that this is a little bit of a forced classification. It's not a bad way to do it, but there are better ways, and the Sicilian gambit, I think, is a much better way to do it, and that's why I'm going to talk about it. So this is the essence of the Singh-Vaughan Williams classification. Different drugs interfere with depolarization at different phases of the depolarization. Some of them, like class 2 and class 5, don't actually interfere with that. It's a bit of a forced system, but the basic idea is where in depolarization do the antidysrhythmics interfere? And that's the basis of their classification. So antidysrhythmics, the class 1 agents are the sodium channel blockers. And you can see on the diagram here, class 1A lengthens the action potential, so it shifts everything a little bit right. Class 1B shortens the action potential, so it shifts everything a little bit left. Class C prolongs the actual phase 0, but everything else catches up, so there isn't really a big difference. And the classic agents in each of these, so class 1A is procainamide, class 1B is xylocaine or lidocaine, depending on where you're from, and propafenone is a class 1C. Again, you don't need to know those for the purposes of undergraduate paramedic education, but it gives you an idea that we have different agents that work in the different areas. There's a way that you can remember the class 1s, double quarter pounder, lettuce, mayo, tomato, more fries, please. If you're studying for medicine and you need to memorize, then that's one way to do it. But this does introduce you to some of the major class 1 sodium channel blockers, antidysrhythmics. You don't need to memorize this, unless your teacher says you do, or unless you're really geeky. So class 2 are the beta blockers, and there are two types of beta blockers. There are cardioselective, and cardioselective only block the beta 1 receptors that are in the heart. Non-cardioselective also block the beta 1 receptors in the heart, but additionally, they block the beta 2 receptors in the lungs. So if you're looking at like a aprenolol or sotalol or propranolol or drugs like that, you shouldn't be giving those to asthmatics and COPD patients because those are people who are having trouble with bronchodilation and you're blocking their ability to bronchodilate. So some of these other drugs like acebutolol, atenolol, metoprolol are drugs that we will carry. In fact, paramedics very commonly carry metoprolol at the next tier level. So metoprolol is not an uncommon drug for us to carry. That's how beta blockers work. Amiodarone is the antidysrhythmic of choice in ventricular tachycardia, pulseless VT, and ventricular fibrillation. So most second-tier paramedics and a lot of first-tier paramedics will carry amiodarone, and amiodarone blocks the potassium channels, prolonging repolarization. If you prolong repolarization, then your heart can't go duck, 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 like it does in VT. It goes duck, 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 duck. We slow it down. So that's what amiodarone does. And amiodarone and lidocaine are probably the most well-known ventricular antidysrhythmics to paramedics because traditionally we always used lidocaine. And then we did a study. Actually, the study was done in Toronto in the 90s. I was part of it, called the ALIVE study. I was just one of the paramedics pushing the drugs. And that study sort of switched us from lidocaine to amiodarone. There are questions about the study. Is amiodarone better? I'm not exactly sure. I'm not sure the science is definitive, but we all use amiodarone. And if amiodarone doesn't work, is it okay to use lidocaine still? Sure, go ahead. So amiodarone is a drug that you will see used out in the field an awful lot. And then the class 5 agents are the calcium channel blockers. And like the beta blockers, there are some calcium channel blockers that work more peripherally and some that work more cardioselectively. Diltiazem and verapamil are examples of that. Verapamil is a bit of a slower acting agent. Diltiazem tends to be the one that we use pre-hospitally because we can give it intravenously. And it's a fairly quick acting calcium channel blocker. So if somebody is in, for example, a symptomatic supraventricular tachycardia, we might start off with adenosine. And if adenosine doesn't work, some paramedics can then do a second line of treatment efforts, and that would be diltiazem as a calcium channel blocker. So they slow heart rate. So class 5 agents are some of the other ones that we carry that just don't fit into the Vaughan Williams classification. We added them on. Digoxin is a big one, and digoxin isn't one that paramedics carry, but it's one that paramedics see an awful lot. You will see patients on digoxin, like all the time. And what digoxin does is it slows down the sodium-potassium pump. If you slow down the potassium pump, it's a lot like parasympathetic innervation. It slows everything else down. So people who have heart failure take digoxin, which slows the sodium-potassium pump, which decreases heart rate. It slows down heart rate, negative chronotrope, and it also increases heart strength. So it's a positive inotrope, which is the perfect drug for somebody in heart failure. Let's slow your heart down. Let's make it a little bit stronger. Obviously, an overdose, patients who've taken too much digoxin get too bradycardic. And I've had a couple really interesting cases of what we call dig toxicity, because digoxin is out there, people take it a lot, it makes them feel better, and they do that common mistake, which non-medical people will do, of if a little is good, then a lot will be better. They take too much digoxin when they're not feeling good. I'll just take a couple extra pills, make myself feel better. They get dig toxic. They go into a brady at like 30 or 40 or something like that, which we can see some characteristic changes on the 12 lead that indicate. But really, just ask them how much drugs have you taken, and it gives you a good idea of dig toxicity. Anybody who's on digoxin, who is bradycardic, you got to have dig toxicity in your differential diagnosis. Adenosine, we've talked about in the previous lecture. It's a drug that paramedics carry. It's good for supraventricular tachycardias that are symptomatic. And mag sulfate, magnesium is like this bizarre sort of wonder drug that seems to work in asthma and ventricular antidysrhythmics and all sorts of stuff. To my understanding, the research for mag as a ventricular antidysrhythmic is not very strong. Most recommendations, the ILCOR recommendations, for example, say that we should be giving it to torsade de pointe that is, witnessed in front of us. In my experience, torsades doesn't last very long. If I see somebody in torsades for more than about 5 minutes as a paramedic, I'm surprised by that. So see if you can get the magnesium in. But it is a ventricular antidysrhythmic, perhaps not a great one, but it's out there, and a lot of paramedics carry magnesium. Okay, so Sicilian gambit. Some guys in I think it was the early 90s or so, took a look at the Vaughan Williams classification. See, I just did it. The Vaughan Williams classification, which was from the early 70s. So, decades later, they said, is there a better way to do this? This paper is up. You can find it, where was it? 91, yeah. So this is available online freely, and you can read it. And if you're into this sort of stuff, it's like, this is awesome. So what they did in the Sicilian gambit is they said, instead of talking about the depolarization, let's go to that diagram, which I've introduced as sort of the rectangular diagram with the voltage-gated channels and the pumps and the exchangers. That diagram I've been using throughout all of this. And they said, let's use that sort of a mental model and talk about using that to classify where antidysrhythmics work. And what do I got here? So they classify the drugs by either voltage-gated channels, receptor-gated channels, pumps, or exchangers, and the way that those drugs affect them, which just to me makes so much more sense. So if you're struggling to learn this stuff, you should know the Vaughan Williams classification, because that's what you'll be asked on tests. That's what you'll be asked by emerge docs and cardiologists who are quizzing you. But if you want to understand it, I think the Sicilian gambit is a much better tool for understanding. And in a nutshell, this is how it works. So we talk about the sodium channels, fast, medium, and slow, calcium channels, potassium channels, funny channels, alpha, beta, muscarinic channels, and the P channels, which are where adenosine work in the AV node, which I didn't talk about. But if you take a look, for example, under P, adenosine is the only one that works there. And there's a bit of a classification, whether it's striped lines or an I or an A or solid or half solid, of how they work. We take a look. Remember I said digoxin works on the sodium, potassium, ATP pump. Well, if we take a look down here, that's where digoxin works. It also has some beta effects. So, or is it? It's not beta. It's muscarinic. Sorry, looking in the wrong line. So you can see if you classify the drugs by where they work, on what channels or receptors or pumps they work on, it actually makes a little bit more sense. That's all the detail I'll go into about the Sicilian gambit. It's just a different way of thinking about antidysrhythmics and how they work. And to me, it makes a lot more sense than trying to cram it into the depolarization, because 2 of the 5 of the Vaughan Williams drug classes don't even fit onto that schemata, but they all fit on here. And as we introduce new drugs, this is where they're going to work. So when you're studying your antidysrhythmics, I would say make sure that you understand what channels, receptors, or pumps they work on, and that will give you a really good understanding of how it works. So what do paramedics in Australia actually use? I've given this Vaughan Williams classification there. We often carry, either at the advanced or the second tier level, ICP, CCP, or MICA in New South Wales. In Victoria, sorry. These are the different sorts of drugs that you'll commonly see. Adenosine, amiodarone, diltiazem, calcium channel blocker, labetalol, alol, obviously a beta blocker, mag, metoprolol, nifedipine, calcium channel blocker, and down here, verapamil, another calcium channel blocker. I've also included oxygen and phenytoin because those work as antidysrhythmics as well. In fact, the first drug you should be giving a patient who's presenting with frequent multiform conducting PVCs is oxygen. Make sure they're at least normoxic, because that's an important drug to do. So I've put those in brackets. We don't typically think of these as antidysrhythmics. In fact, phenytoin is anticonvulsant medication, but it has ventricular antidysrhythmic properties. So I just put that in as a bracket because some of the higher level, usually flight and interfacility critical care transfer paramedics will carry phenytoin as well if our initial attempts at using benzos to stop a seizure doesn't work. So it's in your bag. And if you've got somebody who's just like in an absolutely refractory symptomatic VT and you've thrown a bunch of antidysrhythmics at them, it's kind of a desperate last-ditch effort. But it works as one, so I wanted to introduce it to the idea as well. Okay? So that's it. I just wanted to give you an idea of what we're talking about when we're talking about ventricular antidysrhythmics. So this lecture 9 is really quick, but lecture 0 to, I did the numbering wrong. Lecture 0 to 8, sorry, is a lot of information. And congratulations to you if you've made it all the way through this. You now have, I can promise you, an absolutely solid and comprehensive grasp of electrophysiology, much more than most paramedics will have. I would say that this is the level of electrophysiology that we would expect a doctor to know. Like an emerge doc will know all of this stuff. Cardiologist will know 10 times this stuff. But an emerge doc, as a minimum, will know this stuff. And I think as a minimum, paramedics should be at least familiar with this stuff too. 10 years into your career, you might not be able to sketch out these diagrams anymore, but having a basic idea of how the ions work will give you a lot of strength in understanding the pharmacology that you're introducing into patients. And when something new comes out, you've got that bedrock foundation of cardiac electrophysiology that you can build off of. Probably these are good lectures to go through every 3 or 5 years, as if you're a working paramedic, to make sure that you still remember these things, that you're still up, and that you're still comfortable. Is this going to make you a better clinician? That's a whole different argument. My question is, do you want to be a technician or do you want to be a clinician? If you want to be a clinician, you need to understand what you're doing, not just reflexively do whatever your clinical practice guidelines say, because that's what they say. So, thanks for taking the journey with me. I hope you really enjoyed it. I really enjoyed making these. I've been working on these lectures now for over 10 years. It's nice to finally get them onto the internet. And I hope they really help you. I hope you enjoy them. And if you have any questions, again, feel free to contact me. I'll say it for the last time. All of this information is up for free on paramedicine.com. You can download the lectures from YouTube. You can download the PowerPoints. I'm happy for you to share these with other people. The more we get paramedics knowledgeable about this topic, the more this becomes just sort of the standard expectation within paramedicine. I honestly think the better it will be for our profession, but more importantly, for our patients. So thanks a lot for taking the journey with me. Let me know if you have any questions, and I've really enjoyed doing this.